No issues. Uh, on this for this MAPICON, this new topic type 5 diabetes, again I think it's new for me also. Lot of controversies still there. It's a old diabetes, it's not a new one, but recently because of you say so many meetings, gatherings are happening, and the people are looking for some other sort of cases which are not fitting exactly into type 1, type 2 or other type of diabetes. So they are making a new entity of diabetes as a type 5 diabetes, but still there is a lot of controversies also. So this presentation is only for the controversial presentation, not a exact one. So type 5 diabetes, previously also known as malnutrition related diabetes mellitus, what we called as MRDM. The word is of obesity. Now everyone, we are obese, the BMI is high, and we say the obese people are more prone to become diabetic, developing cardiovascular diseases, so and so and so on. Now, but the entity that those people who have lean BMI, that is a BMI less than 18.5 kilogram per meter square, they are becoming diabetic without any positive family history or without any positive antibodies levels. So the first case, which was seen way back in 1965 by Hughes and Jones in Jamaica, and they found the people are too weak, their BMI is low, they belong to a very poor socioeconomic you say strata, and they are protein deficient also, but they are becoming diabetic. And when they evaluate at that time what the investigations were available, they found they are not type 1 or type 2, but they are a separate type of diabetes. But because of the lack of scientific basis or the lack of you say the investigations, they weren't able to label it, and they labeled as a specific diabetes. If someone recalls the MBBS, it was called as J type of diabetes. So J type of diabetes was nothing but the type MRDM, which was initially labeled in 1965. So does malnutrition play a role in diabetes mellitus? The answer is yes. So malnutrition, we know that it is a nutritional condition which results from imbalance of energy, protein and nutrients. So WHO recognized this malnutrition as a distinct entity and has incorporated MRDM as a category of classification of diabetes in 85. But afterwards also, because ADA is the main society which label as type 1, type 2 diabetes, still, sir, Dr. Vittal has said type 3, type 4 diabetes. Just to remind you, there is no type 3 diabetes, no type 4 diabetes also. So type 3 word is given to other type of diabetes, that is secondary diabetes, which are related to either drug induced or related to some pancreas involvement or related to maternal inherited diabetes, something like that, like the MODI which we used to hear. Then the type 4 is nothing, type 4 we labeled as a gestational diabetes. So still the people are saying ki type 3 is not there, type 4 is not specifically labeled, why labeled lean BMI as a type 5 diabetes? This is again a controversy. So this diabetes is being characterized by insulinopenia. There is a deficient, there is an insulin secretory defect, insulin resistance is there. Some can ask me, the aadmi the palla hi patla hai, the BMI is less than 18, how the resistance is there? And hyperglycemia definitely is there, and there is a partial failure of the beta cells in the pancreas. So the word is very important, it's a partial failure, not a total failure, which we see in type 1 diabetes patients. So the ADA, they reclassified this MRDM into two subgroups. One is fibrocalculous pancreatic diabetes, and second they labeled as a protein deficient pancreatic diabetes or protein deficient diabetes mellitus. So this was the historical timeline or the classification which I was talking you earlier, that is 1985 WHO first introduced MRDM as a distinct category. In 1999, so they again remove MRDM as a distinct category in a revised classification. They thought that it could be a secondary form of diabetes. But lately in 2025, the idea which happened in the Bangkok this year, this was expected, it was expected that they might reconsider classification of MRDM as type 5 diabetes. But still they have not labeled. They have labeled it is a distinct entity, but they have not labeled as a type 5 diabetes. They say you can relate them as a MRDM, not as a type 5. The main work from for this diabetes MRDM was done by our own Dr. Tripathi from Varanasi. So he had a multiple publications long back from Varanasi in the BHU about this diabetes. So looking by the worldwide distribution, if you see, so as awareness regarding the pancreatic diabetes as a separate entity is increasing, Western data reveals 10% of newly diagnosed diabetes belongs to type 5, and they say could be calcific pancreatitis is present in 8% in Uganda and something like that. But in India, the caseload is slightly higher, but the maximum cases, if you see, they are from the African countries, mainly from the Jamaica, Togo, and the Cairo countries. So what are the factors? Why we are becoming MRDM? What the basis reason is this? It is not like that aaj hame malnutrition hogi, we become diabetic. So the story goes back, it's right from the maternal malnutrition. They say if the maternal at the time of pregnancy is taking a low protein diet during pregnancy and lactation, it can cause permanent altered hypothalamic expression of genes in the rat offsprings. So these genes, what are those genes? These are those genes which are involved in insulin signaling, lipid and glucose metabolism, which may outline the metabolic process. And so, if that child is born to a protein deficient mother, if the child nutritional status again is deranged, it is not good, or there is a short period of moderate to very severe undernutrition during the postnatal development, it again increase the risk of developing diabetes later in the adulthood also. So what is MRDM? What are the key characteristics? Key characteristic is, first is age, less than 30 years, number one. Second is BMI, less than 18.5 kilogram per meter square. Third, you can have a history of childhood malnutrition. Fourth, calcification in the pancreas can be there, may not be there. Patient usually they require insulin for the treatment, and in some subset of the patients even your oral anti-diabetic drugs can be effective. The most important is these patients, even if they are off insulin, they won't go into ketosis like in type 1 diabetes, which they cannot survive without insulin for a day or so. So without insulin, where the requirement is high, and the requirement is goes up to 2 units per kilogram of the body weight. If someone is say 50 kgs and the requirement can go up to 100 units in a day, this high much of requirement is there to control the blood glucose level. Last but not the least is absence of autoimmunity. Autoimmunity means looking for those antibodies like GAD65 antibodies, zinc transporter 8 antibodies, ICA or IA2. These are the few antibodies which we usually do when we find this patient might be type 1 or not be type 2, or when we are looking for a LADA onset of patients. Absence of these antibodies, again it is the hallmark of MRDM. So historically we dividing into two categories: fibrocalculous pancreatic diabetes and protein deficient diabetes mellitus. So what are their clinical characteristics? The most important for the FCPD, it is the presence of the pancreatic calcification, what we saw as a pathognomic feature. Usually how they present, the patient they present with the history of recurrent pain abdomen since childhood. There is an evidence of exocrine pancreatic insufficiency. Along with the endocrine, with the patient is becoming diabetic, there is an exocrine pancreatic insufficiency. And how to check the exocrine pancreatic insufficiency? The simple test is do the fecal elastase. That is available. Progressive beta cell failure requiring insulin over the time, and absence of ketosis despite the patient is insulin dependent and the markers, autoimmune markers, are negative. So this is a clinical course. Stage 1, pre-diabetic, just recurrent pain abdomen starting in childhood. With pancreas, you do the ultrasound, calcifications are present, but there is a normal glucose tolerance. Stage 2, transition phase, calcification increased. We have repeated the sonography, the CT scan. Now you did the OGTT, or you find the patient has got impaired glucose tolerance and there is intermittent hyperglycemia. Usually the patient कहता है कदे कदे शुगर बढ़ जाती है जो stress ਹੁੰਦਾ या मिठा खा लेने वैसे शुगर मेरी ठीक रहती है. This is the most common the words by the patients. Third is overt diabetes, when they require insulin therapy for the management, or there is extensive calcification. Extensive means like you say that 50 to 80% of the pancreas is calcified. And last is the advanced stage, when the patient develops microvascular complication, or there is a beta diabetes, kabhi 400, kabhi 40, something like that. And this type of patients who have advanced FCPD, there is increased risk to develop the malignancies. On the contrary, the second part which we is discussing is the PD, that is the protein deficient pancreatic diabetes. In this, there is no pancreatic calcification, but clinically you can see the markers for the protein energy malnutrition. Insulin is required for controlling sugars, but if patient is off insulin, जैसे डॉक्टर मित्तल ने कहा कि यू कांट कीप द इंसुलिन इन योर पॉकेट्स आल्सो, इफ द पेशेंट हैज गॉन समवेयर, इंसुलिन पीछे रहेगी, जो नॉर्मली हमारे सब पेशेंट्स के साथ होता है, दे वॉन्ट गो इनटू कीटोसिस. The last but not the least is low C-peptide levels. If the facilities are available, we can go for the stimulated C-peptide. The C-peptides are there, but on the lower side, meaning by that there is a slight insulin secretion from the pancreas, and possibly there is an exocrine pancreatic insufficiency also. Looking for the pathophysiology. अब इसमें भी गड़बड़ है कि what could be the reasons? Multiple factors are coming into play. Genetic factors are there, nutritional factors are there, protein energy malnutrition is there, so many factors are there which are interplaying with one and another. So one person is saying, I am weak, my BMI is low because my sugars were not controlled. हम पतले हो गए क्योंकि शुगर बढ़ी हुई थी. हम ये कह रहे हैं कि तेरी शुगर जो है वो पतले होने की वजह से है, तो आपस में लड़ाई हो गई. So these are the two things ना. So which we have to be very careful what we are saying and how to address this type of the issues. So dietary factors, we say increased consumption of the cassava which is available in the South Indians. Immune mediated immunological destruction of the beta cell of pancreas. On radiological you can find the calcification, pancreatic dysfunction, nutrition deficiencies in the form of micronutrients, mainly your sulfur containing amino acids, or genetic factors may contribute, which I am just going now. Yes, oxidative stress because of the decreased free radical and peroxidase removal, chronic pancreatic diseases and metabolic abnormalities are there. So multiple factors are there. So these are the few genetic factors which are there in MRDM. The most important is this SPINK-K1 mutation. This mutation is seen in 40 to 50% of FCPD patient. Once there is this gene is mutated, it leads to the premature activation of the trypsin. When trypsin is activated, autophagy will occur, your pancreas starts injured and there will be auto-digestion of the pancreas. Another genes are like PRSS1 and PRSS2 variants. These two things are important for hereditary pancreatitis. Just approximately weeks back, I had one patient, उसके दादाजी died of pancreatitis. Now बेटे को pancreatitis हो गया at the age of 30 years. अब उसका छोटा बेटा आया है at the age of 5 years with the diabetics. So I am just looking for the hereditary pancreatitis in that case, and I am looking for this genetic evaluation, contacted the Gangaram people for this PRSS1 or 2 genes. Then cystic fibrosis transporter receptor variants, we know that, and other candidates like chymotrypsin C, carboxypeptidase A1 and calcium sensing receptors. So these are the few genetic ones which are there. Now another question is, why the people are ketosis resistant? They require a lot of insulin for sugars control, still they are not ketosis. Reason is very simple, because fat ही नहीं है, because of reduced lipolysis, because of the decreased fat store. Second is decreased glucagon secretion, because the cells are not working, your islets is not working, not only the beta but the alpha cells are not working. Still you have got a residual, there is a partial beta cell function which is sufficient to prevent ketogenesis and reduce substrate availability for ketone production. So these are the few things why the patients are not becoming ketotic. So how to diagnose? I think most important is the glycemic assessment, which we do. C-peptide not available anywhere, everywhere. If available, I think we should do it. It is low, but typically not absent. Autoimmune markers, if facility is available, we must go for these 4 antibodies: anti-GAD, anti-IA2, anti-insulin antibodies, or you can go for the zinc transporter 8 antibodies also. If you want to rule out autoimmune pancreatitis, then you have to go for the IgG4 levels. Amylase and lipase may be elevated or may be normal. They are elevated in acute phase settings. We know that. Fecal elastase, I told you earlier, we should do, it should be less than 200 microgram per gram, which suggests the patient has got exocrine pancreatic efficiency. Or you can go for the 72 2 hours fecal fat. I think this is slightly laborious. Imaging, 3 things: ultrasound, CT scans, or through this ERCP or endoscopic sonography. And this is a typical so this is a typical calcification which you see on a plain X-ray of the abdomen, large discrete pancreatic calculi. Remember, अगर पेशेंट अल्कोहलिक है, कैल्सिफिकेशन है, उसमें स्मॉलर कैल्कुलाई होंगे, स्मॉल डक्ट्स में होते हैं. इन FCPD लार्ज कैल्कुलाई इन द लार्जर डक्ट्स. So this is the difference on the sonographics. This is the ultrasound imaging of the pancreas in FCD patient, and this is and ERCP of the FLC patient, where you see the whole pancreas is calcified. So how to diagnose? Clinical suspicion, most important. Evaluation, which we have discussed. Pancreatic imaging, which I have discussed. So the confirmation comes from diabetes plus pancreatic calcification, FCPD. Diabetes, no calcification, patient is lean, BMI is low, sugars are high, consider protein deficient pancreatitis. Be careful labeling them as type 5 because still controversial, but we can label them. So how to differentiate? क्या ये type 1 नहीं है क्योंकि insulin requirement इतनी ज़्यादा है? Type 1 diabetes में usually they have positive antibodies. They are more prone to ketosis. There is no pancreatic calcification, simple, and they cannot live without insulin. In type 2, usually they are higher BMI with strong family history and insulin resistance. In this type of cases, insulin resistance in MRDM is there, but it is lesser as compared to type 2. And in MRDM, there is a slight insulin secretion from our own pancreas also. So the C-peptide is there, but it is a lower side. In type 2, the C-peptides are always higher because of hyperinsulinemic phases. So MODY, which we have to rule out through the genetic testing. There are usually the pedigree charts, 3-4 family history hai, vertical transmission hai, these type of things are there. Alcoholic related may usually you find a different calcification pattern which we have discussed, and there is a history of alcohol abuse. So treatment is control of sugars, nutritional rehabilitation with the help of proteins or multiple vitamin supplements, and the pancreatic sport which we do with this this pan-lipase or other enzymes. So the insulin therapy, you start with a smaller dose of basal acting, then depending upon the you say your requirement, you can go for twice a day or thrice a day or the basal bolus therapies. Oral anti-diabetic drugs can be there, mainly the sulfonylureas and the metformin. DPP-4 does not have a much of role. SGLT2 we should avoid. GLP-1 not much role because of pancreatic involvements. So nutritional, high protein intake, close to 1.2 to 1.5 gram per kilogram of body weight. How much calorie we should give? 35 to 40 kilocalories per kilogram per day. Complex carbs should be 50 to 55% of the total calories. And gone with the micronutrient supplements in the form of vitamin A, D, K, and B, and iron if deficient. So this I think we should know how we should manage this exocrine pancreat with the help of pancreatic enzyme replacement therapies, 10,000, 25,000 or 40,000, and acid suppression might you need. And the most important is the medium chain oils that should be given rather than saturated fats. And if the patient is complaining of pain, the first line therapy is always acetaminophen with a paracetamol. Second line is tramadol, pregabalin, and interventional approaches like celiac plexus blocks, I don't know who is doing it. Endoscopic procedures for ductal obstruction, or you can consider for surgery if there is an intractable pains. Most important is the risk. The risk for pancreatic cancer is very high, and this goes up to 15 to 25 times higher, which typically occurs 10 to 15 years after you have diagnosed the patient with FCPD. So we have to be very careful when you are following this patient, and you can do your CA99, but we say it's not a marker for a follow-up also, but we should know it कि उधर तो नहीं जा रहा. So annual pancreatic imaging either through ultrasound or CT is required once the duration of disease is more than 10 years. So just to summarize, this is a distinct type of pancreatic diabetes, type 3C or 5, what the people are saying. So clinical phenotype is changing because now we are seeing a more better nourished patients with a slightly higher BMI. Now we are seeing in an older population also. I think the hallmark feature is the absence of ketosis despite high glucose and high requirement of insulins. Exocrine pancreatic deficiency may precede onset of diabetes. Chronic pancreatitis and FCPD are pre-malignant condition for pancreatic cancers. So early recognition is essential to avoid the misdiagnosis as type 1 or type 2. Comprehensive management, as we know that we should screen for these complications which can happen earlier, and screening for pancreatic carcinoma is very critical. So just to end, FCD is more than just a disease, it's multifaceted disorder, requires your vigilant multidisciplinary care to prevent complication and to improve the outcomes. Thank you for the patience hearing.